Okay, everyone, let's get started. Welcome to May Town Hall. I'm Pippa Yates, co-founder of Turn.io, and as always, it's such a pleasure to be with this vibrant global community, all committed to using chat and AI to have real impact. I was laughing this morning because here I am sitting in my warm jersey while all of you, those of you on the other side of the world, are stripping off into spring. But we've got a really rich session ahead today. I'm especially excited about today's conversation with Armman, one of our long-standing partners and really doing groundbreaking work in maternal and child health. We're joined by Aparna Hedge, founder of Armman, and recently named one of Time's 100 health leaders. So super excited to have her with us. And Amrita Mahale, who leads product and innovation at Armman. And together they'll be sharing more about the launch of Kilkari and the incredible work they're doing to help millions of women across India access vital health information during their pregnancy and early motherhood. And we'll also be announcing something we've been working on for a while, our new Chat for Health accelerator. So don't miss out on that. We're excited to support health organizations who are looking to scale. And we believe that at the moment, really, we're at one of these really exciting frontiers of digital health, both in the public and the private sector. We can't wait to tell you more about that. But to jump in today, I've got the honor of welcoming 6 new organizations to this Chat for Impact community. First up is Argoya World, who's just launched the M-Diabetes program to educate people in India on diabetes prevention and healthy living through chat. We've got Early Bird Educare at work, Early Bird is building a network of high quality childhood care and education centers across South Africa, and I've had the privilege of meeting their founder, and so excited to have them on board. And we've got Dorcas Africa, who's using mobile tech and low-cost interventions to reduce livestock mortality and tackle zoonotic disease spread in Nigeria. Ayan, working to expand civic participation in Sudan by providing access to trusted and reliable information. The Community Health Impact Coalition, who's advancing the professional community health workers to become the global norm through policy, funding, and international guidelines. So welcome to Sheik. And the Right Walk Foundation, who are advancing equity and justice through systems-driven public policy in education, health, and livelihoods in India. And so we're thrilled to have each of you with us, and we're excited to support you on your journey as you start to use chat and AI to innovate and to grow and make an impact. So without further ado, I'm going to hand over to my fellow co-founder, Gustav Prekap.
Hello, everybody. I'm super excited to be talking to our dear friends Aparna and Amrita from Armman. And just as a quick background here, we've known each other for quite a while.
Yes.
We worked together many years ago in one of the first ever maternal health programs in the world called MAMA, which is the Mobile Alliance for Maternal Action. Aparna, I don't know if you could recall, this is like, I think 15 years ago. And Aparna is the founder and the CEO of Armman, and has many years of, had a vision many years ago of using digital, in those days, SMS to communicate, and SMS and voice to communicate with mothers, and with voice, exactly. And always been inspired by the fact that she had that vision so many years ago, and it's been like, what did I say? It's like overnight success takes 10 or 20 years, and it feels a little bit like that. India, obviously the most populous country in the world, a massive maternal health burden. The maternal health statistics have been improving quite radically in India over the last 10 or 20 years, and I think to no small extent due to the efforts of Aparna and of her team. And I think just incredibly inspired. Obviously, I think one thing that Pippa hasn't mentioned, and well, congratulations, obviously, on the mention and Time most 100 influential people, but also a winner of the Scholar Award for innovation, and just generally speaking, just an amazing partner over the last 10 or 15 years. So maybe just a quick start, Aparna, do you want to maybe just give us just a little bit of a background? It's a quick intro. Why did you start this? How did you get involved in technology? Why maternal health? And just give us a little bit of background about your organization.
Yes. So thank you so much for having us here, Gustav. And as you said, we are really happy to have had this partnership with you since so many years. You and Debbie are like close friends, And when I meet you in meetings, it's always like a sense of kinship. Thank you so much. So Armman started from my experiences during residency in Mumbai. I'm a urogynecologist, and I did my OBGYN residency in Mumbai in a hospital where almost 70% of women and children who ended up requiring care would come in a very delayed, complicated state. And, over and over again, I would see, women and children dying because of completely preventable reasons, and the problem was that we were sitting in antenatal clinics, which were extremely overcrowded, like 200 patients waiting outside. And we are just 3 or 4 of us, and we would not even have a minute of, to spare for every patient, and then they would never come back. Like I've had experiences where I have seen a patient 3rd month of pregnancy, and then the woman has never come back, only to come back dying in labor. And I'm the emergency room doctor, and I open her papers and I see my own handwriting, I've seen her, but she never came back. So the health system always talks about getting the patients to the hospital. But when we are not able to kind of handhold the mothers through pregnancy till the child is 1 year of age, about what are the danger signs, why you need to come for regular care, what are the risk factors and complications, they never access care. And, given the scale of India's problems, it is very obvious to me that I had to go into the community, right, to ensure that, we pick up the risk factors very early and manage in time before it's too late. B, because the huge scale of the problem, anything I designed had to be scalable. And those days are traditional models, you would have NGOs that are working in, slums, a few slums, or, a few villages. And all work is important, but what happens is that when you create a whole parallel network of health workers in a traditional model, you can't scale up those solutions. So you really have to design for scale from day one. And by then, the mobile phone had come to the India and spread like wildfire, right, through the country. And there was no technology. mHealth has not really started by then. Whatever technology that was being used was like they would create devices, a new e-patograph device or some new device. And in a country where you really don't have, a blood pressure machine in half of the primary health centers, you can't expect a new technology device to go across the country, right? So it became very obvious to me when I saw the mobile phone, because it spread through the country like wildfire. Second, in 2008, the iPhone had come, we had a feature phone, I had a flip phone, and iPhone had come in when I just joined Stanford University for my further training. And it became obvious to me that not only will a mobile phone will be available to every woman in every village in India in no time, I also realized something like a smartphone will be in the hands of everybody in no time. And, when the women upgrade themselves, we can upgrade our programs to suit what they have. It seemed like a great tool to reach out to both women and health workers with information and training. So what I realized was, that we have to handhold mothers. And that's where this whole mHealth-based information services directly to the women started through pregnancy till the child is 1 year of age. But we also realized that you have to also train health workers. So we have this whole, we have this 360 degrees approach, right? So we send information to women directly, weekly, till child is 1 year of age through pregnancy and childhood. But we also train health workers. So the frontline health worker called ASHA worker in every village of the country, and the nurse, the medical officer, and the specialist, we train to be able to give the kind of care required early enough before it's too late. So there is a closure of loop of care. So you have reduced number of delayed, complicated, irrational referrals to hospitals like mine, and you have reduction in maternal child mortality and morbidity. It is a very, very difficult journey because I didn't have any technology knowledge. I was a doctor, and I was a fellow studying, but it took me 5 years to get the first penny into Armman. But eventually, the idea of a homegrown, scaled up Indian organization took, root, and people kind of, Mama supported us, And so what we started off with our own program called Mitra. So we started off with voice. SMS would not work in India, I know South Africa, you have SMS, but we started off directly with voice because SMS, we did studies where we realized that women would not, access SMS, would not open, so it was important to do voice-based services. So we started off with voice. And we started off our own program called Mitra. And then we go on to Kilkari. Yeah.
Yeah. No, I think, I mean, and congratulations on that journey. I think it was really insightful for you right in the beginning to recognize that literacy would be an issue. And like you say, knowing already in those days, even though iPhone had just launched, that you'd be able to launch things on smartphones. Maybe one part, I think what's made your journey so unique and so inspiring is also the fact that you started with Amrita and then you managed to pick up Kilkari, which was the national program that I think originally had been developed by BBC Media Action, and I think that really established this as a national program. Maybe give us a little bit of a background, because I think it's quite inspiring for other organizations who are thinking about really going to scale, and that idea of partnerships. How did that transition to, or at least how did you pick up Kilkari?
So it was very obvious to me that whatever we do had to be with the government, because there's true scale only through government. No matter how Amrita worked with the state governments, right? It's worked with the state health hospitals, but obviously funding had to come from the government to be really sustainable. And I realized that we have to prove ourselves with Amrita, and eventually, hopefully, we'll work with the government, national government directly, and that's what happened. So Amrita worked with the state level hospitals, government hospitals, and NGOs on the ground. We went to 3 million women and children in 9 states of the country. And at the same time, just after Amrita was started, BBC Media Action and Gates Foundation started Kilkari. It was a similar program to Amrita. Amrita was like 142 messages, Kilkari 72 messages weekly through pregnancy till the child is 1 year of age. And after BBC had finished 3 years and they were kind of moving out, the government realized, the thing is this, right, that they don't have a technical expertise like in-house. They don't have the knowledge. And by then we really gain that technical know-how, how to manage these kind of unique programs using mHealth. And the government realized they'll be actually watching our success. And they came to us and asked us to take over Kilkari. It was a real surprise, I must tell you, because I had no connections with the government. I'm not a networker. I'm practicing urogynecologist along with Armman founder. So we really had not really knocked on the government doors, but they had watched us, honestly. And, and our dream came true. I mean, I really wanted to work with the government because, and then they asked us to take over Kilkari. We took over Kilkari when Kilkari was around just gone to 13 states. It was in 6 states, and they was just expanding to 13 states, and we took over Kilkari. And I'm very happy to say that along with Kilkari, we also took over Mobile Academy, which is the training program for frontline health workers called ASHA workers. Both were mHealth-based, voice-based solutions. And I'm very happy to say that not only has the partnerships to the instead of persisted till this, for almost 7 years now, we are partnering with the government. Government funds the scale-up of Kilkari program and Mobile Academy program. We fund our own staff. So we have got a co-invested public-private partnership model with the government. Because what we
sorry to interrupt, Aparna. I think for people here listening, I think that's really a unique part, and hopefully something that we could replicate across the global south. This idea that you have, and you came by hook or by crook, by it wasn't as you say, not an easy road, but this idea that you raise the money for innovation and product innovation and developing new tools, and government is responsible for OpEx. I think that is and especially at the moment with all the changes we see in the philanthropic landscape, where there isn't really money from USG and from other sources. So the fact that you've been able to put that in place, I think is really amazing. Maybe, and obviously the fact that you took on the government program as well. So maybe a little bit about seeing that Amrita is here as well. You guys started in voice. You added text with Amrita, and then obviously we started chatting about this idea that you could potentially be using voice or voice audio modules over WhatsApp. Do you want to talk a little bit about like how you then started thinking about how to explore the fact that that so many people have WhatsApp now in India, and how you thought about adding voice to WhatsApp, and how you thought about this collaboration of ours?
Should I take this, Aparna?
Yeah, please go ahead.
Yeah. So at Armman, our approach to innovation is very human-centered, data-driven, and evidence-based. And when we would go and talk to users about their experience with Kilkari, there were some shortcomings that started to emerge. One of the big ones being that a lot of our users have shared phones. So they share the phone with, say, the husband or another family member. So the woman does
Hmm.
not have access to the phone through the day. So it's very easy to miss an IVR call. Even though we made 9 attempts to reach a woman, often the call would connect when the phone is in the hands of the husband and the woman would miss the message. And we've met husbands who actually, replayed the messages or recap the messages for their wives. But that's not all husbands. And a lot of times the intended recipient of the message would not get the message. And then we did a survey to just understand smartphone usage among our users about 2-3 years ago. And we interviewed over 2,000 Kilkari users, and we saw that 65% of them were actually using WhatsApp. And some of them were using it on shared phones.
That's
So we did
amazing.
so we did a small, and this was 3 years ago. I'm sure the numbers are even higher now. More recent informal studies we've done show the number to be even higher, 75-80% in many areas. So we first started with a pilot in Mitra, and Mitra continues to be our sandbox. So Kilkari is our national Ministry of Health program. Mitra continues to be an urban sandbox for Kilkari. So we did a WhatsApp pilot with about 1,000 pregnant women, and the response was phenomenal. And I think almost all women, they were exposed to both IVR and WhatsApp. That was the program design. So for 5 weeks, they received IVR messages. For 5 weeks, they received WhatsApp messages. And the feedback was universally positive. Women appreciated the ability to to watch the messages when they are free and watch them repeatedly, or even share them with family members. It also opened a channel for two-way communication, which was sorely missing in IVR. And two-way communication ranging from just giving feedback about what they liked, what they did not like, to asking questions, to creating opportunities for reinforcement. And all of the
Indeed, yeah.
learnings from the Mitra pilot, as well as a smaller Kilkari pilot we did about a year and a half ago with 500 women, have now shaped the design of the final product. That's just gone live in 2 states, and we'll be adding 2 more states in a month.
So, on a second, congratulations on going live. Aparna.
I just want to add something here, right? When you work with the government, so we because we do this public-private partnership model where we are in charge of innovation, we are keeping one step ahead of what is required, right? So we had been planning
Yeah.
so we already knew we were going to have a fit for purpose approach, in the sense that
Yeah.
based on technology access, we will transform a program. Secondly, based on need, we will have enhanced targeted format programming. So WhatsApp, as it spread across, we already planned for it, right? So when the government gave the go ahead, we were ready. Like we had our
You were ready.
events built up. We had a great person like Amrita joining and managing the product development and doing the pilots. I'm very happy to say that the 4-state pilot is happening on the back of a lot of evidence building. It is not just routine,
Exactly.
yeah, just created overnight just because government now told us, okay, go ahead. We've been planning since last 3 years for it. And one more thing I must say is that the content is gender transformative. It's a very important thing. It's not just that it's WhatsApp, it's videos. And those videos, it's like a drama format following a husband and wife and the extended family and a male peer from the community. Earlier, we would kind of hold a woman responsible for everything that needed to get done. But it's a husband also who should be equally responsible and give equal importance to the wife, and both should be involved in the care. So it's very revolutionary that gender transformative content is getting sent to some of the most underprivileged parts of the country, including tribal in India. Yeah.
And I want to double click on that for the audience here. And I definitely want to share that as well. And super inspiring for those who haven't seen it. These videos are really fun. And like you say, they are gender transformative. And something that Amrita has said, which I really want to reiterate, is this idea, which I don't think we necessarily thought about before when we started this journey together, is that these clips, these audio and video clips, can also be shared. And so they become objects which users can watch. Amrita, I just want to again, what you both said is they can watch it over and over again. And that's so different from just having a IVR line. I think that's really powerful. And the other thing you mentioned, and I'd like to know more about that, is this idea that you have a sandbox for testing, a Mitra, and then scale up with government. And not all countries can do that, but I think there's something to be learned there of having a continual place where you can learn. So one question I've got for either of you, Amrita, you mentioned something about the fact that it opens up bidirectional communication. And so I think that's maybe one thing. How are you thinking now? The end user, the mom, is seeing this video content and she can text back, but obviously also, this raised the question that I know you guys have been testing AI. So obviously this raised the idea of bidirectional conversation. How are you thinking about things like voice conversations, multimodal, or AI? I mean, everybody's saying that at the moment. How are you, seeing that you're staying one step ahead of the game? How are you thinking about this in the next couple of years and utilizing these other tools?
Yeah, so
Amrita, you can.
yeah. So for Kilkari and Amrita, the two-way communication is currently mostly limited to interactive messages. So we send feedback questions from time to time. We send quizzes to reinforce the key messages in the videos we send them. Sometimes we send layered content where a woman who's interested to learn more can just press a button and get additional videos instead of overwhelming, a user who may not be very, very engaged. So that's on the end user side. We have been experimenting with AI, with LLMs in our health worker facing. So we follow responsible AI principles and we wanted to prioritize safety. So we decided to start building LLM products for health workers who are a slightly more digitally savvy audience. So we expect them to be able to exercise, some cautious skepticism, healthy skepticism towards AI answers. So we decided to start with the auxiliary nurse midwife for our first chatbot. So we have a chatbot that's live in 3 districts of UP, and it answers A&M questions about high-risk pregnancy. This is part of a different program. It's our high-risk pregnancy program. And we're just starting some evaluations in Telugu as well. So it's a multilingual, multimodal chatbot. And the response has been phenomenal. It's been live in pilot mode for about 4 months and live with
Super exciting.
about 750 A&Ms for a little over a month, also on the Turn platform. And
do you see, so the same way that those learnings, then what you could see, if you see enough take up and you feel safe enough, then you're in a position to potentially scale that out. Are you thinking about this? I know you're using for health workers. Do you think we're ready yet? Or when do you see a world where you exposing that LLM technology to moms directly as well?
Yeah, in July. So we are working on human evaluations. So we have a phase-wise approach to LLM evaluations before we roll anything out in the field. So we now have doctors, grading the model we've built on exams we've set for it. I think we'll be ready to launch in a couple of months.
This is so exciting. I mean, I must say, I always come away from, I know this is an interview, but every time I have a chat with Aparna and with you, Amrita, I kind of just get so excited about the scale, obviously, and the impact you guys are having. It's just super inspiring, really. And especially the way that you guys are doing it, even though it's so large scale, still being able to be first to market with voice messaging, first to market with some of these technologies, and having that feedback loop from real users, I think is super exciting. Maybe I know we're getting a little bit too close to the end of the conversation. Maybe if you think ahead, this has been. I know it feels like yesterday, Aparna, that we spoke, in the Nitro days, and I think it was 2010 when we first met. And here we are in 2025, and you have the national program. You at the forefront of experimentation for both of you. It's 2030. We are. I'm interviewing you in 2030. Where are we? How many people have we reached? What do you see? What is your vision for the future?
Amrita, you can go ahead first. Yeah.
Maybe you can start with the overall vision, Aparna. Then I'll bring
it's okay. Yes. So our whole overall vision is 100 million women and their children, and 1 million health workers. Right. So 100 million women and health workers, women and children handheld in a fit for purpose approach, meaning that if you have low risk women and children, you will have basic content, but all gender transferable content using multimedia. But if you've got high risk factor or equity encumbered, right? Like if you are a scheduled caste, scheduled tribe mother, you're a Rosin mother, you're a migrant mother, if you're a Muslim mother, your healthcare access is poor. So, for these subgroups that have got, so much of inequity, and the women and children with high risk factors, we'll have more and more targeted content, more two-way communication, more, long-term handholding. so that they
Yeah.
are, they obviously access care. And the other hand, train health workers at every level of the health system. So this whole training is not just training, right? It's training using multimedia sources, two-way communication, long-term hand-holding, and then tracking of the women and children with high-risk factors so that we can go back and do iterative program improvement, all with AI incorporated in every aspect of programming so that we can improve program efficiency and also develop wonderful Gen AI-based models to go across to both health workers and women with, two-way communication. Yeah, Amrita.
Yeah.
Yeah, I think
Small
Aparna.
goal. Only 100 million.
Yeah.
Amrita, sorry.
No, I mean, I think Aparna has covered everything. And I think we see our service getting a lot more personalized, right? Using AI, we see potential for a lot more personalization, more risk stratification, leading to better personalization as well. So yeah, AI is going to be a big part of our product suite going forward.
Amazing. So small goals, only 100 million people, and hyper-personalization, being able to connect with every mother in India, multimodally in the language that she speaks. We've got our marching orders. I see there's a question from the audience, which I think is very relevant, especially in other countries. I think maybe India is unique here, but it would be great to have your feedback here. Either Amrita, or it's a bit of a technical question. Mark Eringer is asking, in high-risk pregnancies, obviously the digital part is very important, but Aparna, you mentioned that the health outcome is very closely related to being able to do the referral. You want the mother to come back, especially in high-risk pregnancies. So a question here is, like, in India, do you have a up-to-date, I think that's the case. In India, you have a database of all the health facilities, so you can refer a mother back to that. Maybe just a thought about that. How is that maintained? Is that a function of the Indian health system already doing that? Like, and how are you thinking about referrals? And do you have advice for organizations where they might be working in situations where there isn't such a resource available for referrals?
So, India does have a database, a live database of mothers and children, but the database quality is poor. So we're really working with the states, every state literally where we're working. We've got state teams built out to work with the state government to improve the data quality at every level. So, really, emphasizing on the need for improved data quality, especially having phone numbers, etc. ready, because those are things that people don't bother about, right? Even if they do the healthcare work properly. So improving data quality, improving accountability, improving data-driven action by sending analyzed data back to them so that they can use it for, prioritization of work and data-driven, action. So we're really working with the states at every level to improve, to ensure that data of the databases improves. But even in those places where data quality, that nothing of this exists, that you don't have this database, you don't have a network already built up. In Mumbai, I'll give an example, right? It all came from that, right? I was sitting in the antenatal clinics where you had these high-risk women coming. We would diagnose them to have high-risk factors. They would go away, never to be traced, never to be tracked down. You never know what would happen to them. And what we're doing right now is that in the same hospitals where I saw this, we have this whole system where as soon as a woman is picked up as having high-risk factors, see, it's like the health workers in the field supposed to get the woman to the hospitals. When they come to the hospitals and they're diagnosed to have a high-risk factor, the nurse diagnoses the high-risk factor. We have a system where we get to know that information, we get that information ASAP, right? So that that information then is fed into the government database. And we are hoping now to direct the data back to the field, to the community health worker, so that she knows that this woman from her field has this high-risk factor. Otherwise, there was no linkage like that before. So she can then go and ensure that the woman comes back for care, right? Because there was no linkage between the tertiary system and the primary care system. So we are actually in a city like Mumbai, right? I mean, we are actually actively working with the Municipal Corporation Mumbai to develop this system of, ensuring, there's a 360-degree thing in the tertiary hospital linked to the primary setup, primary care.
So I just want to close up by saying it's always a joy to interview you guys. It's really amazing to work with you. I know sometimes it feels like building these systems for such large rollouts is a long and complex and tiring road. But just from I know from our audience, from the team at Turn, I know from the other organizations, you guys are an inspiration. The work that you do is incredibly inspiring. we look forward to supporting you and helping you reach that goal. The largest maternal health system, actually, I think it'll probably be the large health system in the world once you hit those goals. And I think coming back to the core heart of it is empowering every single mother with information that she needs to make the decisions that she wants to make to improve the lives of her family. And Aparna and Amrita, I just want to say thank you so much. You guys are inspiration, and thanks for sharing your wisdom and your successes. And yeah, we look forward to working with you guys in future.
Thank you so much.
Thank you.
All right. Hi, everyone. And again, just reiterating, thank you. I don't know. I'm always a bit lost for words in this moment because the things you guys are doing are just so amazing. 100 million, that's an amazing number that we want to help you with. And we're always thinking about ways where we can support you and achieve your goals and have this real amazing impact in the world. It was funny you were talking about how your experience was with what WhatsApp enabled you to do. One of the things that came up to me was the fact that literacy rates in India, despite have been growing, there's still a couple of gaps, right? There's a gender gap and where women's literacy rate is lower, and then there's also a location gap where people in rural areas have a lower literacy rate. And we're always thinking about how we can make tools that enable you to reach these people who tend to be the ones that are less privileged and have less access to life-changing information. You talked about AI, and one of the features that we have in the product already is the ability to generate audio messages with AI, where you can actually have a voice-enabled journey. And another of the initiatives we've been thinking about that will make access to information and care universal is calling. So let's get to the next slide, please. We've been working really hard on this. It's not the first time we talk about voice calls here on the town hall. One of the major drivers for this initiative altogether was to enable people with low literacy to get the same level of care as everyone else. But more than that, it's in the context of patient care. A personal, friendly voice can be the deciding factor in someone making a better choice for their life. And all of this happening not in like a personal phone call with your personal number, but in a secure platform that people trust and that people feel safe in sharing some more personal details that will be completely determinant to the level of care that they can get. In terms of new developments, and it's interesting because it ties to something you mentioned, Amrita. We're currently trialing the ability to for organizations to be able to call their users, which is going to unlock a series of use cases. For example, scheduling calls where someone can be expecting a call at a certain time, and that example you gave earlier around maybe the phone not being with the mother all the time. They could expect a call at a certain time that they scheduled at their convenience. Or another use case that this opens up is following up with people or calling back to a missed call. Something we've already been testing for the last couple of months is actually the ability for a user to call an organization, which gives them complete control over when this call happens, which is really, really good. We'll keep you up to date with new developments when this gets released to everyone. This is currently going on a private beta. If you want to be a part of this beta, please do get in touch either via support or here through the chat, and someone from the team will get back to you. Next slide, please. If you were here in the last town hall, you might have heard us talk about piloting our new inbox. This has been going well. If I can say so myself, this has been a great success. I think the team is really proud with what we've done. This is one of the key parts of our product. Most of you interact with this all day long, every day, and we were very intentional with the changes that we made and how we made them and how we roll them out. And I'm happy to say that this is going to roll out to everyone soon. Just to reiterate some of the advantages of this new inbox, it's much faster, it's much snappier. Considering that some of you work on this tool every day, all day long, it's going to be more joyful. it's better, it's more readable, it reduces eye strain, it increases some density of information to reduce unnecessarily scrolling, and lets you refer to patient history and or conversation history much easier. There's better label management. There's all sorts of new things that are coming that make it much better. For a few weeks, and we'll communicate this clearly when this actually hits the product, you'll be able to revert back to the old inbox in case something goes wrong or something's not working as intended. Of course, we'd love it if you could flag this with us if it does happen. It helps us make it better for everyone else. And then when we're confident that everything is set, we're going to be disabling the old box altogether after a few weeks. And now, without further ado, we have some community news to share.
Thanks, Ricardo.
We can skip this slide, yeah.
Yeah, good. Thanks, Ricardo. I think, as you all know, we value the community as a tremendous, not just for sharing information, but also getting your input. So we would like to share with you today, you're the first to be partisan to this information, but we are launching a new accelerator. The accelerator, Neil, if we can go to the next slide. The accelerator is a chat and AI health focus accelerator. We are looking for 10 high potential organizations ready to design, test, and scale your models using chat and AI. What we are looking for, and specifically focusing on this accelerator, is we're going to be looking at scalable and sustainable models. So at the end of the accelerator, not only will you have a WhatsApp and chat service with AI elements, you will have an investment-ready solution. So we really want to focus on that throughout the accelerator. You'll get access to an advanced technology toolkit. So that aligns perfectly with the information that Ricardo just shared. So that includes our multimodal AI agents, including calling, which still is in beta. So this is really hot off the press, available to accelerator participants. You'll get access to our help desk, our Journey no-code builder. So all of this is available for you to use throughout the accelerator period. Then you'll also access all our experts. I don't know how many of you know, but we've got an amazing team of experts and also partners that will be partnering with us throughout this accelerator, right through from AI and conversational design and engineering to behavioral change and digital health specialists, go-to-market specialists. And throughout this whole program, these specialists will work alongside you and your team to ensure that your service is built, but also ready for scale. Then you will also become part of a community. We all know how important community is, but this time around, it's not just community, we're building out case studies. This allows you to track your impact, measure what's working, what's not, and have an investment-ready product and case study ready for when you are ready to scale. Moving on, we are looking for certain use cases. If your use case is not one of these, don't worry. We will review all use cases coming in, but these are some of the priority ones we're looking at. So if you are looking at patient education, appointment preparation, any kind of telehealth appointment reminders, we would like to hear from you. And then lastly, who should apply? We are looking for organizations that are ready to scale. You've already been chatting about this solution internally, so you've got everyone in your team on board. You're ambitious. We really want you to think big. And although we will work with you through to develop sustainable models, we would love for you to have thought about that in terms of how you're going to keep this chat service sustainable. Do you have a go-to-market plan in place? So you don't have to have everything perfect, but at least have thought through about that. The conversational mindset. So you're at the stage of your journey where you know that chat and AI is the main solution for you to go forward faster, and some maturity in terms of your technical usage. So again, you don't have to be an engineer or developer, but at least be comfortable building out your own services using our very easy to use platform. So we hope that you have are excited and already thinking about what you will apply for, we will be sharing through the application within the community once it's ready. But for the meantime, I just want to highlight this amazing opportunity. We can only fill 10 seats, so I really hope that you start thinking about what you want to submit in terms of your use case, and we look forward to getting your submissions. More information on when and where to apply will be shared in the community firsthand. And I think that's over to Pippa now.
Thanks so much, Lisa. I'm so excited that we have another Health Accelerator coming up because we always get so amazingly, pleasantly surprised about the different use cases that people submit. And there's always things that surprise us. There's always innovative things happening or ideas that are in the back of your minds that you want to help scale, and you've got a model. So this is your opportunity. So very excited. Please don't hesitate to reach out and apply. And we'll, as Lisa said, we'll share those details as and when they're available. But I just want to say a big thank you to everyone for joining Town Hall today, and especially to Aparna and Amrita, really for all the incredible work you're doing at Armman. I think you take our breath away in many ways with just the scale of the ambition and the innovation that's happening within your organization, and the model of using your kind of test bed in Amrita and the health worker facing programs to kind of roll things out. We're super excited about the future and to reach those 100 million moms, and we're here with you to help make that happen. But I think just on reflection of today's session, your health systems everywhere, both on the public and in the private sector, need smarter, more human ways to engage with people, whether that's those with low literacy or those that share access to phones or those who just want to get on and have a call. And we are very excited at this point to be able to support all of these use cases and to see the growth of these new channels such as WhatsApp calls starting to be used in this ecosystem. So thank you so much for joining us today, for being part of this movement, and we look forward to building this new digital health future together in the coming years. We'll see you